Alright, so the next topic is infective endocarditis. So that is another disease that people can present with, and usually they don't have necessarily chest pain. Their chief complaint, like I said earlier, is not going to be chest pain, but if it is present, it's going to be constant chest pain. Most common chief complaint is going to be fever. So they have very high grade fever with chills. They may have some shortness of breath, some dizziness because of reduced cardiac output, but usually it's just high grade fever. And if chest pain is present, it's not your typical cardiac chest pain, it's just constant chest pain. Again, as you recall from your fever module, they have risk factors. So the biggest risk factors are going to be IV drug use. So this patient can be quite young if they've been using IV drugs, and they can also be at risk if they have any prosthetic device. So any foreign body, for example, catheter, orthopedic device, artificial valve, or a structural heart disease. So you can see all these risk factors can be present even in younger population. So it doesn't have to be your older age group, it can be anybody who's basically either self-inflicted some problems, or they are in an unfortunate situation where now they are at risk for infective endocarditis. So if it does develop, then other than these symptoms, they have these signs of fever. They may have an S3, usually S3 gallop, which basically means tachycardia, and then they also have a murmur if depending upon whatever valve is involved. Usually mitral valve is involved, so that's why you'll hear the murmur of mitral regurgitation. Roth spots can be present in the eyes, then osseous nodes on the fingers, then Janeway lesions will be present on the palms, and splinter hemorrhages on the nails. So these are just classic textbook physical exam findings on infective endocarditis. We don't always see them all together. You'd be lucky if you see one or two in one patient, but these are heavily tested on the exam, so therefore keep them in mind. Then the complications of infective endocarditis would be heart failure is one big complication. Hypotension is another complication, so the patients may become very hypotensive because of reduced cardiac output. They may go into hypotensive shock or cardiogenic shock. They also may develop a thrombus, so that is a very big complication, and the thrombus will embolize, and of course it can go to the brain. So everything from the heart will go to the brain, everything from leg will go to the lung, so just keep that in mind. And this stroke, this embolus that goes to the brain will cause a stroke, and this stroke will look really bad because this is a septic embolism. So that's why it's going to be a very unfortunate situation. So try to avoid that, of course, these complications. Try to start antibiotics very early on. These are the findings that may be present. So these Roth spots in the eyes, you have Janeway lesions, you have osseous nodes, and you have splinter hemorrhages. Here is the echocardiogram. So you have mitral valve most frequently involved, and you have aortic valve in some situations. In IV drug users, a tricuspid valve can be involved as well. Here is the murmur of the mitral regurgitation. So you can hear it right here. I hope it's loud enough. So you can see there is a pan-systolic murmur starting from S1 to S2 and going all the way. So this is a mitral regurgitation murmur in the mitral area. Okay, so the next is a real quick review, and we already discussed it in fever, but IV drug users usually have staph, and then strep bovis is usually in colon cancer. Then you can also have strep viridans in abnormal valves, strep epidermidis in prosthetic valves, and then you have Hayes-Sack and enterococcus organisms. Then treatment would be removal of the prosthetic valve. You may need some parenteral antibiotics in the form of vancomycin, treatment of the failure, and then finally surgery if medical treatment fails. There is a little typo here, so this is HACK. Alright, so the next is myocarditis. So again, myocarditis is the infection of the myocardium. So this is supposed to be a pretty big serious infection, but because it is a virus infection, it usually doesn't present very dramatically. So usually people have constant chest pain. It's not very typical cardiac ischemia chest pain. So this is going to be your regular, constant, not very severe chest pain. The course is going to be a few days or even weeks. and not a few hours or a couple of days. So that's the difference. And people also have usually low grade fever with shortness of breath and fatigue. So that is going to be your presentation, and risk factors are going to be some preceding viral illness. So people will usually come in and say that they were sick a few weeks ago with some upper respiratory infection, and now they are sick with some chest pain, and the fever has just not gone away, and they are very, very fatigued. So that's how myocarditis will present. They usually have a history of travel. A lot of these viruses come from outside the country, so there is something to keep in mind. The most common virus is parvovirus, so just keep that in mind. Parvovirus will cause myocarditis very commonly. Then physical exam findings will be fever, so they may have S3 and S4 gallop. They may also develop complications. So again, very similar complications. They get heart failure, of course myocardium is not working. They get hypotension and cardiogenic shock. They can also develop pericarditis and dilated cardiomyopathy. So remember from our dyspnea talk that people with myocarditis and endocarditis can develop dilated cardiomyopathy, and finally they can develop left ventricular dysfunction, and then heart failure with reduced ejection fraction. So that's what's happening here. So obviously the goal is to prevent this complication from happening. The diagnostic test would be, if you're suspecting it in the setting of these symptoms and signs, you are going to do EKG that will show some STT wave changes. There may be some rhythm abnormalities because of the myocardium involvement. Chest x-ray will not necessarily show much, but if myocardium has dilated, then you'll see dilated heart. Troponins may be somewhat elevated, but again this is going to be very subtle. And then you can do BNP. This will be high only if the patient has developed heart failure, so it's not going to rise otherwise necessarily. Echocardiogram will give you some clue as far as the inflammation is concerned. As far as the heart failure is concerned, so that will give you pretty good idea that patient has myocarditis, because now they have reduced ejection fraction with fever, and they have some risk factors too. Finally, the test that will make the final diagnosis would be cardiac MRI or biopsy. And finally, again, the most common virus is parvovirus that will cause this. Here is a slide showing that this patient had dilated cardiomyopathy as a result of myocarditis. So they had some enlarged heart right here after an acute upper respiratory illness, but then they went on to develop massive myocarditis and dilated cardiomyopathy with heart failure, and now they have pulmonary edema that is causing a lot of shortness of breath. So this is the complication, and the patient is looking much more sick 3 months later. So the next thing is pericarditis that can definitely cause chest pain. So how do these patients present? So their chest pain is very classic, because their chest pain is going to be relieved by leaning forward. So patients will come in and they'll say that they have chest pain, they get better when they lean forward, therefore they continue to lean forward a lot. So that is basically the story. On top of that, their chest pain is usually sharp and very pleuritic too. So when they take a deep breath in, they have chest pain. Usually this finding or this piece of symptom will be added on to this when they have pleuropericarditis. So pleuropericarditis is basically inflammation of the pleura and the pericardium adjacent to each other, and therefore patients have both of these symptoms present. They also have, of course, shortness of breath, and they may or may not have low grade fever. So fever, even if it is present, it's going to be low grade. Risk factors are going to be, again, there are some risk factors, but the most common is idiopathic. So idiopathic causes of pericarditis, or basically idiopathic cause is one cause which is the most common cause of pericarditis. So keep that in mind. This does not help because you don't really know what to do with it. Then the next most common cause or risk factor is recent MI. So the story would be that the patient had an MI recently, and they just started to get better, but within a couple of days they developed chest pain that was different from their original chest pain, and now this chest pain gets better when they lean forward, and you go on to visit them and they are leaning forward on their bed or their table. So on top of that, they start to develop low-grade fever, so we call that Dressler syndrome. So that is something to keep in mind. Additional risk factors are going to be, of course, your viral myocarditis. We just talked about it. It can cause pericarditis. Tuberculosis can cause it too. Then connective tissue diseases, uremia as a complication can cause uremic pericarditis, and neoplasia or any malignancies can also cause pericarditis. Then radiation treatment due to chemotherapy or for any cancer treatment will also put a patient at risk for pericarditis and ultimately pericardial effusion. So these are the things to keep in mind. Now, pericarditis in itself is not very life-threatening. It of course is painful, and pain usually starts to go away, because typically what happens with these people is that either they get better and completely improve, or they start to develop pericardial effusion, which is another complication. So in that case, they don't get better. Their pain does go away, because effusion will get rid of the inflammation or irritation of the pericardium, but because of the effusion and tamponade, they start to get worse. So what happens before that develops, on the physical exam, pericarditis will show some pericardial friction rub. So this is a very classic finding. If you hear it, then definitely you can make a clinical diagnosis. The diagnostic test to do whenever you're suspecting this would be EKG. It will show some ST changes, very non-specific usually, and then echocardiogram will give you some information too. Now, if these patients don't get better, then like I said earlier, they will develop pericardial effusion or cardiac tamponade. Basically, cardiac tamponade is the same thing, except that it's too much effusion and it's now causing pressure on the heart. So then we call it cardiac tamponade. In this case, patients are usually hemodynamically unstable. They have hypotension now set in, and this happens more commonly in the setting of radiation. So after radiation treatment from different malignancies, for example Hodgkin lymphomas or non-Hodgkin lymphomas, people start to develop an irritation, and then finally they develop cardiac tamponade, and ultimately they move on to develop cardiogenic shock. So cardiac tamponade patients are going to have not only some dyspnea. So among all these features, only shortness of breath will remain. Everything else will start to go away. So you won't see any pain. You wouldn't hear your patient complain about chest pain. A rub will go away too, but on top of shortness of breath, now on physical exam they will have pulsus paradoxus, which is basically a drop in blood pressure of more than 10 millimeter mercury when they take a deep breath in, and then also they will have laterally displaced PMI. So basically point of maximum impulse will be laterally displaced, because now they have a lot of effusion. So these are some things to keep in mind. Here is the audio for pericardial rub. So pericardial rub is going to be a scratchy sound throughout the cardiac cycle. So it's not systolic or diastolic, it is just continuous sound. So this is what you can this is what you will hear. So you can see it is rhythmic along the cardiac cycle, but it's not systolic or diastolic. So that is a rub. And here is an EKG. So again, EKG can show some very non-specific findings, but this particular slide is showing that there is some diffuse upsloping of ST waves in lead 2 and AVF. So that's what you see here. And here is a chest x-ray. So apparently this patient had a recent cabbage, and then there is a massive effusion, and usually the effusion has to be more than 200 cc to show on the x-ray. This is definitely much more than 200 cc, so the patient is obviously pretty sick here. This is an echocardiogram, and you've already seen effusion on echo. So this is pericardial fluid, and it's all the way around. So how do we treat pericarditis? So not the effusion. If there is effusion, of course you will tap it, but if there is just pericarditis, it has not become effusion yet, you can treat the patient with non-steroidal anti-inflammatory medicines. You can give them colchicine for viral or idiopathic pericarditis. For post-MI patients, you can do aspirin and colchicine. It is going to be better that you do aspirin instead of NSAIDs. Patients who have autoimmune disorders and that is causing pericarditis, you can do steroids. And for all other patients who have underlying etiology, for example uremia or anything like that, you will treat the underlying etiology. The only thing to keep in mind is do not give them heparin, because heparin will cause hemorrhagic pericardial effusion, so you just need to avoid that. Next is pleurisy or pleuritic chest pain. So patients can also develop, just like pericarditis, they can have pleuritis, and the term used here is pleurisy. So these patients usually have chest pain that is worse with inspiration. So when they take a deep breath in, they say the chest pain gets worse. Very classic finding, and whenever it is present, it's usually a sign that there is irritation of the pleura. So usually the pain is going to be unilateral, because obviously usually one side is involved, and they may have some shortness of breath too. Now again, pleurisy is going to be a secondary complication. So this is going to be pain secondary to another problem or pathology going on. So it doesn't just develop out of nowhere. There is usually another problem. For example, patient may just have pneumonia, patient may have a recent PE, or patient may have something else, some other process going on in the lung parenchyma, and now the overlying pleura is involved. Or even pericarditis patients can develop pleuritic inflammation, and that is pleuropericarditis. So that is something to keep in mind. So therefore the risk factors would be either recent pneumonia, or even malignancies or metastatic lesions can cause it. Patients with TB infection or connective tissue disorders, for example lupus or rheumatoid arthritis, they can go ahead and develop pleuritis, and that's how they present with chest pain, which is worse with inspiration. So remember from our dyspnea talk that these patients not only have chest pain and but also shortness of breath. But if patient has pleural effusion, those patients don't necessarily have chest pain, they only show up with shortness of breath. So that is the distinction to keep in mind. So on physical exam, patients have pleural rub. So just like pericardial rub, there is a scratchy sound that you can correlate with respiratory cycle, not the cardiac cycle. And then usually it is heard over the lung, not over the heart. And then there will be sign of pleural effusion if the pleuritis progresses to become pleural effusion, in which case there is dullness to percussion and there is decreased breath sounds. Chest x-ray will usually not show anything if it's simple pleurisy, but if effusion has developed, then you will see effusion on the chest x-ray. And of course treatment is treat the underlying cause. The next is aortic stenosis. So we already talked about aortic stenosis in the context of dyspnea, but again these patients can present with exertional chest pain. So if they do present with chest pain, it is going to be very exertional, so very similar to cardiac ischemia chest pain, but this time they not just have chest pain, they also have shortness of breath and syncope. In syncope, if it presents, it is usually a late sign, and it is an indication for surgery. So keep that in mind. So they don't always have syncope. Whenever you have somebody coming in with exertional chest pain and shortness of breath, in addition to thinking that the patient may have cardiac ischemia, you can also think about aortic stenosis. And it is quite easy to distinguish between aortic stenosis and cardiac ischemia by doing physical exam, and we'll talk about that in a second here. So the pain will be substernal, usually radiating to the jaw, so not radiating to the left side, and it usually goes to the jaw, and it's usually a pressure like pain or squeeze. And again, syncope can be present. Usually it's going to be very transient loss of consciousness. Risk factors are going to be basically these. So older patients, again, unfortunately can get aortic stenosis. Patients who smoke, so long history of smoking will place anybody at risk for aortic stenosis. and again male patients are at higher risk, and patients with congenital bicuspid valve will develop aortic stenosis also at a relatively younger age. So if somebody comes in and they are quite young, in their 40s or 50s, and they have the symptoms, but you also know from their history that they have a congenital valve, then you can start thinking about aortic stenosis. So you can see that these risk factors are very similar to the cardiac ischemia risk factors. So therefore it becomes very important to take a good history, because there are some distinguishing features here, and do a good exam that will distinguish between aortic stenosis versus cardiac ischemia. So these patients usually on exam have ejection systolic murmur, and the murmur is radiating to the neck, and usually they also have S4 because they have left ventricular hypertrophy because of stenosis. So these findings will be present on exam. Not both of them necessarily are going to be present, but if you hear any systolic murmur or ejection systolic murmur in the aortic area, then you definitely got to think about aortic stenosis. The diagnostic test of choice would be echocardiogram. So you'll do the echo and you'll see the stenosis very quickly. EKG will probably just show LVH and nothing else, and then chest x-ray may show some prominent aortic arch. Troponins will be usually normal unless the patient is seeing you during the time when they have exertional chest pain, but in between the episodes they are usually normal. So this is a slide that you already seen. So this is aortic stenosis. You can see the valve is very stenotic, and here is the murmur of aortic stenosis. So again, this is going to be your systolic murmur, so starting from S1 to S2. So this is going to be ejection systolic murmur, and here is how it sounds like. Okay, so